Happy New Year, everyone. Welcome to 2021, our Let's Talk Parkinson's webinar. We will be continuing to do this every month, every Monday, first Monday of the month. And today we are starting off in the very good start for 2021. We do have our um, medical director for the Pacific Movement Disorder Center. So it is a great source of information as we did by starting with Dr. Diaz last year in December. Now we do have Dr. Petrosian. I think she is known to every one of you and don't really need an introduction, but just a little bit of background. Dr. Petrosian um, is a native of Southern California. She graduated summa cum laude in UCLA, did her residency and fellowship at the Brigham General Hospital and Massachusetts General Hospital in Brigham and Women's Hospital, which is affiliated with the Harvard School of Medicine in Boston, Massachusetts. And she has been our medical director here at the Pacific Movement Disorder Center under the Pacific Neuroscience Institute since 2016, 17, Dr. P, huh? When we started. So without further ado, Happy New Year to everyone. And please, help me welcome Dr. Melita Petrossian.
Thank you so much. And I did also want to say that this is being recorded and we will upload the recording to our website, pacificmovement.org, sometime this week. If people are unable to join it, it'll be, as well as, so people don't feel stressed of having to write things down. The slides will be available this way as well. So I'm going to share my screen so that let me know, can you guys see my slides? Okay, all right. So today we're really going to be focusing just on the motor symptoms of Parkinson's. There's obviously a lot that we can talk about. So I'm going to try to be more focused today on just medications for motor symptoms of Parkinson's disease. So let's see, hold on. So we'll briefly discuss what those motor manifestations are, some medication options for both early and advanced stages, as well as some tips and some frequently asked questions that we've received. So Parkinson's has what we call motor, meaning movement related, and non-motor manifestations. And again, bear in mind that not everybody experiences these symptoms, and it's not that everybody's going to experience every single one of these symptoms at some point along the course of their condition, but these are just common symptoms of Parkinson's. What we call bradykinesia is a slowing down of movements. It's when movements become slower, stiffer, smaller. People can describe their movements as walking through molasses or quicksand. Sometimes the fine motor movements can become impaired, less natural feeling. People may have changes in their voice or facial expressions. Reduced frequency of swallow can cause drooling. There can be loss of the automatic movements of walking, such as reduced arm swing, and smaller handwriting, as well as even a little bit of a slower cognitive processing. Rigidity refers to the stiffness in the muscles. That's something that we really assess on the examination upon moving the arms and legs and assessing for this a relaxability of the arms, of the limbs. So there can be an increased resistance and less ability of the muscles to relax. Rest tremor refers to tremor which is present when the limb is or the jaw is at rest, meaning not being supported, meaning being supported against gravity, not being used. Sometimes people with Parkinson's will have other kinds of tremor, but the most common or most typical is rest tremor. About a third of people with Parkinson's never develop tremor. And actually the majority of people who have tremor don't have Parkinson's. And then of course, postural instability, meaning kind of a tipping backwards or a falling backwards, sometimes in other directions as well, a loss of the natural ability to regain the center of gravity. And finally, there's a term we call freezing, which is when while walking, people can get stuck, especially upon initiating gait, upon turning, upon going through doorways. Again, we're not going to be talking today about management of non-motor symptoms such as constipation or dizziness upon standing or mood symptoms. That will be a talk at a later date. So talking about how do we treat these motor symptoms. So the concept is that these symptoms are caused by low dopamine in the brain. So the majority of what we do is just try to re-supplement the dopamine from one angle or another. So the most common is utilizing the precursor to dopamine, which is called levodopa, also known as L-Dopa. That has to get into the brain, and then it has to get converted into dopamine. Dopamine then acts on what are called receptors. A receptor is like a lock and dopamine is like the key. Dopamine receptors can also be acted on by what are called dopamine agonists, which are like a separate or a different key that fits in the same lock. Those are these here. And then the dopamine then gets metabolized, meaning it gets broken down and then it gets rebuilt again. So the ways that we can manage that is by, again, adding in the precursor, which is levodopa, using a dopamine agonist that works on the same receptors, or reducing the metabolism of dopamine by inhibiting or blocking the breakdown or metabolism of dopamine or levodopa. So we'll go over these medications individually, but this is sort of an overview of where they all fit. So the mainstay of Parkinson's treatment is levodopa, again, the precursor to dopamine. It's also known as L-Dopa, Carbidopa, levodopa, Sinemet. All of these are essentially synonymous with each other. I will often use the word Sinemet instead of Carbidopa, levodopa, mainly because it has 3 syllables instead of 8. Rytary is a different formulation of Carbidopa, levodopa, which is not exactly the same as Sinemet formulations. We'll get into that later, but it is the same drug. So this gray line here represents the blood-brain barrier. And again, the concept is that the levodopa has to get into the brain in order to get converted into dopamine. When levodopa gets converted to dopamine outside of the brain, so this left half of in front of the gray line is considered outside of the brain, what we call the periphery. Then the dopamine in the periphery can cause side effects like nausea and lightheadedness, like low blood pressure. This is why we don't give dopamine as a drug, because giving dopamine can drop blood pressure and cause nausea. I should say we don't use it to treat Parkinson's. So what we do is we give carbidopa with the levodopa, and the carbidopa blocks this enzyme called dopa decarboxylase, and therefore minimizes the conversion into dopamine outside of the brain and maximizes the levodopa getting into the brain and then getting converted into dopamine inside the brain. So the clever term that they came up with when Sinemet was branded is a play on the Latin sin, meaning without, and emit from the word emesis, meaning nausea or vomiting. So the concept of Sinemet being you wouldn't vomit by taking Sinemet compared to if you were taking levodopa on its own. The reality is, of course, that some people still get nausea with Sinemet, but that's why we always give carbidopa with levodopa. But the idea is that the active drug is the levodopa. And the ratio is typically 1 to 4, 25 milligrams of carbidopa to every 100 milligrams of levodopa. Again, like I said, it comes as Sinemet immediate and controlled release, also available as an orally disintegrating form, which I find useful if somebody's having trouble swallowing. You can put it under the tongue. Then, of course, Rytary we'll get into. Pros and cons of levodopa as a treatment. It is the most effective medication for Parkinson's, but some people may experience nausea, lightheadedness, dizziness, and fogginess, which will typically dissipate with taking a low dose, increasing slowly, gradually getting accustomed to the medication. Confusion and hallucinations can occur in older patients or those with dementia. And as the disease progresses, the reaction or the response to the medication can shift and can be associated with what are called dyskinesias, which are abnormal involuntary movements. These do not include tremor, but the involuntary movements that we used to see with Michael J. Fox, for example, are called dyskinesias. And also the medication can last shorter number of hours during the day and can take longer to kick in. Dopamine agonists, as I mentioned before, act on the same receptors as natural dopamine. These include pramipexole, which is Mirapex, ropinirole, which is Requip, retigotine, which is the patch, the 24-hour patch called Nupro, and then epimorphine, which is available in 2 forms, Apikin and Kinmobi. Epimorphine has nothing to do with morphine. It's not related at all to the opiates. It just has a similar sounding name. And we'll talk about that one separately. Pros and cons of using dopamine agonist is that they do not cause dyskinesias and they're not associated with motor fluctuations. However, they are less effective than levodopa, and some patients can experience somnolence, swelling, and hallucinations. Especially older people have a harder time tolerating the dopamine agonists. And even younger people can experience what are called impulse control disorders, including reckless spending, gambling, compulsive eating, and even sexual misbehaviors. And they can also experience what is thought to be a withdrawal syndrome. So it can be very challenging to manage those kinds of impulse control situations when patients may not recognize that the drug is causing a problem and may really have a hard time coming off of it. And it can really be problematic for both the patient and the family. Mao B inhibitors are very mild medications, meaning they're really not particularly effective, but they do work by reducing the breakdown of natural dopamine. They have fewer side effects than either the dopamine agonist or levodopa. They do not cause dyskinesias or fluctuations in general. They are available in 3 different formulations. The oldest is called selegiline, Eldepril. That one's a twice-a-day medication. Rasagiline is a once-a-day medication, also known as Azilek. And then the newest one is called sulfonamide, which is Xadago. Or is it Xadago? I think it's Xadago. Yeah, Xadago. And so Xadago is the newest, so maybe people have heard about it as advertised that, it's a new medication for Parkinson's. Xadago has not been approved for treatment on its own, which is what we call monotherapy, and it has not been compared to the older Mao B inhibitors. So we don't know whether it's superior to the older meds. We only know that it is newer. The other con with the Mao B inhibitors, in addition to the fact that it's less effective, is that it can, of course, cause nausea, lightheadedness, insomnia, and anxiety. Bearing in mind when we talk about side effects is that not everybody experiences these. Most people do not experience side effects with Mao B inhibitors, and they are typically, they would go away with continued use, and obviously they would definitely go away when the medication is stopped. But they can also interact with other medications, namely antidepressants and over-the-counter medications. So what happens as the years go by with levodopa? So on the left side of the screen, we have earlier stages, and in the right half, we have later stages. And in the beginning, people will have most people will experience a time period where the medication's working relatively well. They don't really notice when it's kicking in or wearing off. And so with 3 doses a day, they are able to have good control of their symptoms. The blue sort of in the middle here, we'll call that well controlled. That means that more mobility, easier movements, less stiffness, less slowness. If we imagine that too little dopamine is the experience of the Parkinson's symptom prior to getting treated with levodopa, slowness, stiffness, we call that being off in the context of the medication has worn off or it never kicked in, but we will still call that off time. If we imagine what too much dopamine is doing, it's causing dyskinesias, again, those involuntary movements. So in an earlier stage, most of the time, people are able to remain within those 3 doses within that on period during the day without a lot of dyskinesias or off time. Unless, of course, they skip meds, which is incredibly common. We don't really consider that as like the motor complication of off time because that's, well, you just didn't take your med on time kind of thing. Then as the years go by, the reaction to the medication can shift. Why? Because the brain is continuing to change as the disease is going on. Unfortunately, the brain's ability to create natural dopamine continues to decline as the years are going by. Therefore, the underlying dopamine levels are lower. Also, the brain's enzyme to convert levodopa into dopamine is getting reduced. And the brain's, the other kind of circuitry in terms of how the brain then responds to dopamine is also going a bit awry. So there's several factors that play a role in the off time of the medication not kicking in quickly enough or taking longer to kick in. And then when it does kick in, experiencing off dyskinesias and then wearing off too quickly, so that the good amount of time is a shorter time per day. So we call that on time is reduced, off time is increased, or dyskinesias are increased. Sorry, let me see if I can. So then, sorry, let me go back to the screen. There we go. Again, definitions of what we were discussing earlier. I do want to mention that people can also experience what we call non-motor fluctuations, which are usually experienced as fatigue, sometimes nausea, sometimes a little bit of shortness of breath when they're feeling off. And that gets better when they are taking their medications. And these are more recently identified, is a more recently identified phenomenon. People really were only thinking about what we could see objectively, but now we're understanding that people are experiencing symptoms that aren't really apparent externally. We call that non-motor. And then within 5 years of treatment with levodopa, about 50% of people will be experiencing dyskinesias, but only 20% will find them troublesome. And I want to emphasize that for people who have not experienced dyskinesias, there's a great fear of dyskinesias. And it's very much out of proportion to the actual disruption to one's life that people who are actually experiencing dyskinesias will report. I would say, as it says, 20% of dyskinesias are truly bothersome. Going from the other direction, I would say 20% of people who are having dyskinesias are not aware, and not even their family is necessarily aware that it's a dyskinesia. So for example, I'll be examining somebody and maybe they're having a little bit of a head nod like this, and I'll ask them about dyskinesias and they'll say, I'm not having dyskinesias, and their family will not be aware of it either. Another 20%, the patient is not aware, but the family is noticing that, maybe the jaw is moving or the head is moving. Another 20%, the patient is aware, but really not bothered at all. And then another 20%, it's annoying, something that the patient would really prefer not to have, but not so much that it's really disruptive to their life. And again, about 20% is truly bothersome and disruptive and really becoming a problem. 40% of people who've been taking levodopa for 5 years are experiencing troublesome on-off fluctuations, meaning the med is taking too long to kick in or not lasting long enough. But I want to emphasize, when we use this term within 5 years, it does not mean that there is this 5-year magical time that everybody's hunky-dory, and then all of a sudden 5 years later, where it stops working. It just means when we've looked at people who've been taking it for 5 years, this is the percentage of people who are experiencing these symptoms. But some people will experience dyskinesias earlier. Some people will experience it later. There's not a magic number of years that levodopa is going to last for. And we'll talk a little bit about that later. So how can we manage off time? There's several ways. One is, the oldest way that we used to do this before we developed longer-acting levodopa was people would just take levodopa more frequently. 3 times a day became 4, 4 would become 5, 6, 7, and then you have people taking levodopa 8 times a day, which I think is a bit ridiculous and a bit, challenging to ask patients to do, as well as the fact that people start to feel like they're shackled to their medication. So, and the more that you do take levodopa, the higher the risk of dyskinesias. So a lot of work has been done and a lot of success has been found with how do we make these medications last longer? How do we deal with off time? And we'll get into, so what can we do instead of just going down that road of more and more and more frequency of taking the medication? Controlled release carbidopa levodopa is available. It doesn't get absorbed quite as consistently, so it's not been as easy to use as you would think in terms of actually working well for making levodopa last longer. And then more recently, an extended release capsule form of carbidopa levodopa known as Rytary was developed. Now, as you can see, Rytary is actually 2 separate components put together. One, which is in this sort of dashed line here, is actually the one on the bottom, I misspoke, excuse me, is a kind of a basal rate, if you will. And then the other one is going to be like a higher peak. And then when you put them together, you'll get as early of a response as your immediate release, which is this dotted line, but it's going to last longer than the immediate release, which is going to kind of wear off around that, 3 or 4 hour mark here. So it does come in different formulations, and it is not dose equivalent to Sinemet. So it does not have the same equivalence, and therefore what we do is we say we convert the dose from Sinemet to Rytary, usually by doubling it. Most people will require a doubling of the dose. That doesn't mean they're going up on the dose. It just means when you look at the numbers, it looks like a doubling. It's not really. The ratio of the conversion varies from person to person. For some people, a 2-to-1 ratio isn't enough, and for some it's too much. So we do need to play around a little bit at the beginning with the medication to find the right dose for each person individually. But I always like to give the analogy that it's like when you convert your money from dollars to pounds, you may be looking at a different denomination, but the value should be the same. And the numbers are confusing because they have these non-round numbers, but the bottom line is it comes as a 95, 145, 195, and 245. And those numbers reflect the amount of levodopa. And it is still in a 1-to-4 ratio with carbidopa. And those are the numbers that are reflected on the pill itself, written right on it. So that's the easiest way to call them, is just calling them by their amount of levodopa, 95, 145, 195, and 245. And if the capsule is too large for someone to swallow, it can be opened and sprinkled onto applesauce. Because they are micro beads of extended release, they are still going to last just as long and kick in just as quickly as if it's taken as a whole. And then how do we make levodopa last even longer? Well, Duopa is a little bit more cumbersome way of doing this, but it is the same Carbidopa levodopa. It just gets infused directly. Let's just bypass the stomach and go directly into the intestine, using essentially a feeding tube, but not used as a feeding tube, just used to administer medication. And you can see that it requires an external pump and a cartridge that gets clicked in every morning. It's meant to be used for 16 hours and then turned off at bedtime. The idea is that it's going to make it a smoother release during the day. People can have issues with the tube, and there have been reports of neuropathy, but usually those kinds of side effects are within the first couple of weeks and then they resolve themselves. In the future, we're expecting to see a patch pump form of Carbidopa levodopa. There are two companies that are creating this right now. One of them is called Neuroderm and the other one is from AbbVie. And they're both recruiting phase 3 trials in a couple of locations locally. The concept of this is that it is a liquid form that gets then converted into a patch, kind of like an insulin pump, essentially. And then instead of having to take pills and go up and down in the levels, to have it be a smoother amount during the day, but not have to go through the GI tract the way Duopa does. There also has been work done on something called an accordion pill you may have read about. The concept of this is that it's the same Carbidopa levodopa, but they are putting it in, instead of in a regular just capsule form or tablet form, within that capsule, they put something that is folded like an accordion. And these are biodegradable films that are meant to slow the release and just make it last longer within the GI tract. Unfortunately, the phase 3 trial did not meet its primary endpoint of improving off time compared to immediate release levodopa. But they believe that the problem that they had was they were underdosing in the trial. So the company is trying to find a partner to pursue another phase 3 trial looking more specifically at higher doses. I'm not sure if when that's going to happen. And then they're also saying that they're working on a newer technology that will hopefully be a 24-hour a medication. With this particular accordion pill was meant to be a 3 times a day. So, you know, that's something that we can look out for in the future. So how else can we make levodopa last longer? Well, going back to what we have here is we can work on breaking down the dopamine, but we can also work to reduce the breakdown of levodopa itself. And the way we do that is with COMT inhibitors. And the two that are available now are called entacapone and opicapone. Opicapone is a newer one. It is a once-a-day medication that makes the levodopa last longer. Entacapone, it has been around for longer, but has to be given with each dose of levodopa. Again, these are not medications that do anything for Parkinson's on their own, because they only work to reduce the breakdown of levodopa, not dopamine. So they have to be given with levodopa. As I said, the pro is that they can improve on time. However, they can exacerbate dyskinesias and other levodopa side effects. So those levodopa side effects we talked about earlier, like low blood pressure, hallucinations, or even impulse control, they can be exacerbated by making more levodopa stick around. And they can also cause somnolence. So again, just to say it one more time, when we talk about can cause, it doesn't mean everybody is experiencing this. Obviously, the majority of people are experiencing an improvement rather than side effect. It's just that when we try a medication, we don't know which individual is going to experience the benefit versus the side effect. And that's why we just have to give things a try. Okay, so then moving away from how do we prevent off time by making levodopa last longer, now let's talk about people who have what we call unpredictable off periods. And this can happen where it's not consistent. Sometimes the medication kicked in just fine and sometimes it didn't. And sometimes there's a clear explanation, like for example, maybe they took it with food or too close to a meal. But sometimes there's no explanation as to why they're experiencing off time. So there's two treatments that are available as a, it's called a rescue medication. I like to call it a bridge because the idea is that it will get you from where you are to that point where your next oral dose will kick in. Both of these rescue or bridge medications are pretty short acting. They're not meant to last all day. They're not really even going to last very, very long. They're just meant to get people to that point where their next drug is going to kick in. So the concept is that for somebody who doesn't need to go up on all of their doses, it's only happening sporadically, it's good to have a backup option. And the other nice thing about a rescue option is that if somebody, a lot of people will experience, who do have off time, will experience a sense of not wanting to go out because they don't know if they'll be able to then drive back home, depending on when their medication is kicking in or wearing off. So this way, if somebody's out and about and, oh dear, you know, my med didn't kick in and I need to find a way to drive home, that kind of thing. Not while driving, of course, you know, in a safe way, people can have this in, you know, their purse or what have you, and be able to not get stuck when they're out of the house. So this particular one, Inbrija, is an inhaled levodopa. It bypasses the GI tract, which is really helpful because the gut has slowed down in people with Parkinson's. So you're having to rely on a gut that isn't working as quickly as it ought to be in order to get the treatment that you need. So by inhaling the levodopa, you're bypassing that gut, and it does kick in pretty quickly within about 5 or 15 minutes. But it doesn't last extremely long. It will last about an hour or more. And it is not something that people can take on their own. It has to be taken with carbidopa, levodopa, with the oral medication, either the Sinemet or the, you know, the generic or the Rytari, because there's no carbidopa in it. So people can experience cough or changes in the color or the thickness of the sputum. People can sometimes feel like they're having an upper respiratory infection. But there are ways to try to get around that by breathing in more slowly, by drinking water before and after. And so when people get used to how to do it, many patients feel like it's helpful. But again, it's one of those things that people, if it's appropriate, should just try it. Again, the con is that it does not prevent off time. And again, just to clarify, it comes with this inhaler and capsules, and each dose is 2 capsules. So you do one and then you have to do it all over again. And the capsules say on there, do not swallow. They look like a capsule, but they're not meant to be swallowed. They're just for placing into the inhaler and then breathing in. And again, really, really important to breathe slowly. Okay, so the next rescue medication is called Kinmobi, which is sublingual epimorphine. I apologize because I realize I don't have a slide on the oldest, I should say, the first rescue medication for Parkinson's, which is called Apikin, which is also apomorphine, but that one's an injection like into the thigh, for example. And both forms, because they are apomorphine, require people to take an oral anti-nausea medication for 3 days prior to prevent nausea, because they're very, very likely to cause nausea. So people have to like kind of pre-medicate with an anti-nausea medication, and then they can start using this. The sublingual epimorphine is a film. I don't know if you guys remember those Listerine films from back in the day, where it was like this little strip that you would put for improving breath. But this one doesn't go on top of the tongue, it goes under the tongue. And the packaging is in a very, very child-proof and almost adult-proof packaging, because of the fact that there was concern that since it looks like a film, that children could mistake it for, you know, a breath freshener or something like that. But the idea is that you open up the packaging, you get a strip, you drink water, very important to drink water, put the strip under the tongue, and then you can't swallow, you can't talk for as long as it takes for that film to fully disintegrate, so that it's not, you don't want to swallow it. You're not trying to get it into, you know, your GI tract. You're trying to get it be absorbed directly into the blood vessels of the sublingual space, meaning the space under the tongue. It does kick in within 30 minutes. It lasts about an hour or two, but it can cause oral swelling and redness in the area, lightheadedness, somnolence, and fatigue. The clinical trial did not show the other, and again, sorry, just to remind people that I mentioned this earlier, apomorphine works as a dopamine agonist. It's in that same class of drugs as pramipexole, which is Mirapex, ropinirole, which is Requip. Now, in the trial, they did not see any cases of impulse control disorders that we worry about with the dopamine agonist, or withdrawal syndromes, but it was a shorter trial, so I don't know whether people would be at risk of that. And again, just as with the Inbrija, it does not prevent off time. It's really a reaction to off time. And then there's completely shift gears away from dopamine. There is a class of medication called Adenosine A2a Antagonists. An antagonist is a drug that blocks an action rather than promoting an action like an agonist would. So this one is called Estradiphalene, also known as Nurians. This is the one that was originally developed in Japan. And I tried to find a diagram of the brain's, what we call basal ganglia, which I like to call the autopilot of the brain. I tried to find a diagram of the indirect versus the direct pathway. And even the simplest diagram was just way too complicated for the purposes of this talk. The concept is that we basically have, with subconsciously in that autopilot, we have a go signal and we have a no-go signal, or a stop signal. And we have to have the proper balance of stop and go. For example, if you're trying to cross a street or you're walking along with your friend and you don't have to normally pay attention to, I got to the crosswalk, I am going to stop walking. Now the light has turned green, now I'm going to start walking. All of that stop and start needs to happen pretty much subconsciously. And the natural way that happens is with what we call the indirect and the direct pathway. And again, the most simplistic way to think about it is that the indirect pathway inhibits movement, is like a stop sign, and the direct pathway promotes movement. This is extremely simplified, and obviously it's much more complicated in reality. In addition to dopamine, and in addition to a whole other group of brain chemicals, which we call neurotransmitters, which I will not discuss, there is a brain chemical or neurotransmitter called adenosine A2a. And there are adenosine A2a receptors in the indirect pathway. So the thought is that adenosine works to cause that indirect pathway to block or inhibit movement, whereas dopamine is promoting movement. So the way to think about why Nurians was developed was because it's not enough just to promote movement by giving more dopamine. We also have to stop that blocking of movement that's coming from adenosine A2a in order to better balance things. And so this is all, I should say, mostly theoretical, because if you read the package insert of Nurians, it will say it blocks adenosine A2a, but we don't really know how it works in Parkinson's. But that's the theory why it works, is that there's adenosine A2a receptors on the indirect pathway. So we're trying to block that blocking from the indirect pathway. Okay, so pros and cons. It's a once-a-day medication. It reduces off times. It can exacerbate dyskinesia and also cause hallucinations, but it tends to be pretty well tolerated. And again, for people who are experiencing off time, worth a try. I should say, I think one thing I didn't add into the pros and cons of a lot of these things is a lot of these meds are expensive, but that's a whole other talk. And I guess I'm working in a bubble right now, so we'll ignore that for now. Okay, so we talked about off time. What about dyskinesias? Again, dyskinesias are involuntary movements typically associated with just too high of a dose of levodopa. But for many people, they may experience that dose, that window where it's too much versus too little can become kind of narrow. And I have had people experience dyskinesias at very low doses as well. So it's not purely dose dependent, but it is what we call levodopa induced. So important way to think about this is that both the disease and the levodopa are contributing to the development of dyskinesias. It is not the same as a side effect where it would happen to anybody who took levodopa. That is to say, there are people who take levodopa for other diseases and they don't develop dyskinesias. So it is really an intersection between the drug and the disease. If somebody had Parkinson's and never took levodopa, they would never get dyskinesias, but they would also be pretty disabled and very unhappy in general. So how can we manage it? We can reduce the levodopa dose to a certain extent, and we can add in amantadine, which is an NMDA receptor antagonist. It also works to release dopamine intrinsically and was originally designed as an antiviral medication, which is kind of becoming more interesting now. But it had been used for dyskinesias for a couple decades at least, until the extended release formulations were developed were FDA approved in 2017 and 2018. So the companies kind of advertised Gocovri as like the only FDA approved medication for dyskinesias, which is technically true, but it's the same medication. It's a amantadine that's been around forever. It's just a different formulation. Again, similar to the Xadago that I discussed earlier, these meds get compared to placebo. So I can't comment on whether Gocovri or Osmolex are any more effective or any more tolerable than immediate release amantadine. We only know how they compare to placebo. We do know that all three of these medications can cause insomnia, hallucinations, and edema. But again, the majority of people can tolerate it. Then, what we're not going to talk too much about today is what do we do when we've tried all the meds and nothing has worked? Right now, the next step would be surgical treatment options like deep brain stimulation. That will be a talk at a later date. Did want to kind of mention that both for treatment of dyskinesias and for off time, as well as for treatment of tremor, because what I didn't mention earlier is that people who have tremor predominant Parkinson's may sometimes require a really high dose of levodopa for the tremor to be improved. And sometimes it's just not tolerable to take those high doses. And so deep brain stimulation surgery is also treatment for people who have tremor that's not being adequately managed by medication. Okay, so switching gears to talking about what I get asked a lot is, I'm in an early stage. What do I do now? When do I start medication? It is very, very important to state clearly that levodopa does not prevent progression of Parkinson's disease, but it also does not accelerate the progression of Parkinson's disease. There have been multiple studies trying to ask that question of, is it too early? Is it too late? And the most recent one that was published last year did not show any downside to starting the levodopa early. Like there wasn't any increased risk of dyskinesias by starting earlier. But in that trial, early was, 40 weeks earlier than the delayed start group. So it's not like we're talking about year 1 versus year 5. I think the consensus is that the complications of levodopa treatment meaning off time, and dyskinesias are related to the dose of the medication and the duration of the disease. And there's not a sense that it's related to the time of when levodopa was started. So the current consensus is that if somebody is having slowness or stiffness that is not managed by lifestyle modifications like exercise, which we'll talk about in a different talk, then they should start on medication for whatever their symptoms are without unnecessary delay, but they should be trying to be on a lower dose rather than an excessively high dose. I like to say, take the dose you need, don't take more than you need. Not so much that people should be suffering and forcing themselves to be on lower doses, but just that, not to overdo it, not to just willy-nilly go up on the dose. I don't think any of us do anything willy-nilly. By the way, I do see that there's questions, and I see that people have hands raised. We will get time. We do definitely have time to get to questions. Just a couple more slides here. Some tips on taking medications. Levodopa should typically be taken on an empty stomach to improve absorption. I do advise people to take the meds on a set schedule, the same time of day, every day. None of us can remember to take meds on time. It is not humanly possible to naturally remember to take meds on time every day at the same time every day. I recommend setting a recurring alarm. It's really easy to do on your smartphone. There are medication watches and other ways of doing timers if people don't have a smartphone. But there's a lot of gadgets and devices out there to help people take meds on time. It is really important. Why is it important? Because there's evidence that when people take their levodopa, I should say, there's animal evidence that when animals are given levodopa in what we call a pulsatile form, meaning up and down and up and down and up and down, the dose is going, the brain level is going, they're more likely to get dyskinesias. Whereas if they got a continuous infusion of levodopa, they would really be at a much lower risk of getting dyskinesias. So the concept is, don't take your meds sporadically, take it consistently. Try your best to take it on an empty stomach. But even if you're going to be late with a meal, it's much better to take that med on time rather than having to delay it and then think about, well, I took it at 1, now I'm going to wait for 4 hours and like drive yourself crazy. Don't drive yourself crazy, but just try to be like, army regimented. This is the time I take my med, and I try my best to set my meal schedule around that. I do also recommend that people keep a log of the medications they've tried, both currently and what they've been on in the past, especially if people go to see a second opinion for Parkinson's. It's really helpful for that next physician to know, oh, you've already tried X, Y, or Z, and what was the dose, and why didn't it work, or, why did it work, or what have you. And then also bear in mind, hopefully people are staying out of the hospital now, but if anybody does need to be hospitalized, most of these newer medications are not on formulary. What that means is that the hospital is not going to have it in their pharmacy. And so in order, especially with Rytary, in order to get that smooth on time and not get set back in the hospitalization, it is recommended to bring your medication from home. The nurse will take that from you, will send it to the pharmacy. The pharmacy will identify it, log it, and then dispense it back through the nurse with each dose. You can't keep your meds in your purse at your bedside when you're in the hospital. That will not work. But it is important to bring it with you because most hospitals don't have these things on formulary. And then very, very important, medications are not enough. Lifestyle factors, exercise, sleep, diet, social engagement, cognitive stimulation are absolutely vital. And Giselle will talk about that next month. I also wanted people to be aware that you can go to Parkinson.org and download this information. It's called Aware and Care. You can have a list of medications that are unsafe versus safe. And that's helpful because very unfortunately, this is a little bit, embarrassing to admit, but many hospitalists, pharmacists, nurses, surgeons, anesthesiologists may not be as familiar with Parkinson's as you and your family have become. And so they may not really immediately remember that, I shouldn't be giving this Parkinson's patient Reglan. There's a little bit of a knee jerk of post-op nausea, let's give Reglan. And so it's sometimes helpful to remind, the hospitalist team or the nurses, or even as an outpatient, if you're going to see, let's say a GI doc or a urologist or something, like, actually, can you make sure that this med is safe for me in terms of not interacting with the disease itself and not interacting with other Parkinson's meds? We're totally open to, if people send us my chart messages or phone calls, so-and-so prescribed me this, is it okay? I mean, you can also ask the pharmacist as well. But, just bear in mind that it is helpful to educate yourself about, what is safe and what is better to avoid, let's put it that way. And again, I'm also adding in urology type medications like oxybutynin, which is ditropan, which can definitely cause confusion in people who have dementia or in the elderly, as well as a lot of people with Parkinson's have what is called orthostatic hypotension, where their blood pressure can drop, and meds like alpha blockers, like tamsulosin, which is Flomax, can cause that as well. So again, that's on parkinson.org, and you can just download all of the printables, or you can ask for the kit. And so in summary, we have 9 new medications that got FDA approved for the treatment of motor symptoms of Parkinson's since 2014. And I just really want to say that this is huge. This is something that I think can really inspire hope and optimism to our patients, that, as frustrating as it is to kind of feel the slowness of, I read about this, doc, when's it going to come out? And then it's like, well, no, that was just an animal, slow your horses, that kind of thing. And yes, it is true that none of these medications are cures, and they don't prevent progression of Parkinson's disease. The fact is that there's so much we can do for people's quality of life. And there's so many options that we have. Really, I think our main limitation is, who's paying for these medications is a big problem in the States. But other than that, I think it's very, very optimistic that a lot of progress has been made. And it obviously makes me optimistic for the future as well, for further medications that will become available. So on that note, I'm going to stop here and again remind you, next month is Giselle talking about lifestyle treatment options, and now we can get to questions. Should I just read them myself? I see, are there cognitive issues with over-medication? Yes, if the dose is too high, people can get confused or feel out of it or foggy. What's new with feedback loops with DBS? I am going to defer that question because we are going to have a DBS talk. Short answer is that we do at Providence have the BrainSense Medtronic device. Unfortunately, right now we're on hold with elective procedures, as you can imagine. But it's on the cusp of actually being a true feedback. We'll talk about that. Oh, somebody just deleted their answer, I guess. Any other questions? Let me see. Did people have their hands raised?
Some of them I'm sorry. Some of them I answered. Just typed it in, so
got it. Okay.
In the answered portion.
Okay, and let me see. There's 4 people with hands raised. I'm not sure if people want me to call on them because we were sort of doing this more as confidential, but if people who have their hands raised want to type in a question, that's the best way to do it. Let's see. Oh, this is a good question. Can too much exercise deplete dopamine long-term? No, definitely not. I actually heard somebody who had been exercising and feeling good. I just met this person recently, and then she said that she read a book by somebody whose name I've completely like blocked in my mind. And that person had said, oh, exercise is bad for Parkinson's because it depletes, you need to save the dopamine that you have. So she stopped exercising and then she was just like progressing horribly. And I was like, oh my God, like throw that book out. Who is saying this? Okay, so again, I feel like I don't want to steal thunder from Giselle, but the concept is that exercise does not improve the amount of dopamine, but it does make people use dopamine more efficiently. And it makes the dopamine receptors more present, and it does other things too in the brain. Question about what would be the once a day medication that has been proven to work that you recommend? Well, so the one once a day medication that is available as monotherapy is rasagiline, which is Azilek. And for some of my patients who have an early stage mild symptoms, I recommend it as mild treatment. However, for people who it's not enough for them and they need to be on levodopa, it's not, none of those are available as once a day. And then Nurians is a once a day, but it doesn't work on its own. It has to be given with levodopa. Now there are dopamine agonists, which are once a day, like Mirapex and Requip are available as extended release, but even then most people do take it more than once a day. And then there's a new Pro patch, which is a 24-hour patch. So that's a once a day. So really it depends on the person, what their potential is for developing side effects. It's all very much needs to be individualized. There isn't like necessarily one med that everybody has to be on, I would say. Okay, you mentioned that 30% of PD patients do not have tremors. However, patients with tremors do not have something. I did not catch what you said. I was saying that the majority of people with tremor don't have Parkinson's. So there's a different condition called essential tremor, which is not Parkinson's, and that's much more common than Parkinson's. Oh, and then I think the other thing I had said was people with tremor predominant Parkinson's, meaning tremor is the main symptom of their Parkinson's, often require a higher dose of levodopa to treat their symptoms.
Dr. T, there are a few questions in the chat.
Oh, okay. Do medications for depression and or anxiety cause PD? That is a very good question. PD is Parkinson's disease. So the short answer is no. The longer answer is there are medications that can cause somebody to look like they've got Parkinson's. We call that drug-induced Parkinsonism. It's not the same as a drug causing a disease, because once the drug is taken away, that appearance of Parkinsonism goes away and they're not degenerating, like the brain cells aren't dying the way Parkinson's disease is. But mainly those medications are antipsychotics because they block dopamine. So by blocking dopamine, you can make somebody look like they've got Parkinson's. And more recently, some psychiatrists are using antipsychotics, meaning dopamine blocking meds, as an adjunct for depression, like Abilify is that one that got FDA approved, not simply for schizophrenia or other things that antipsychotics are typically used for, but as an adjunct for treatment of depression. So if somebody has Parkinson's disease, they should not be on Abilify. But if somebody comes to me and they're on Abilify, I'm going to blame the Abilify until, and see how they do off of Abilify. There was a question about meds for hallucinations and dementia. Again, that's going to be more of a non-motor, so I'm going to defer that question. Question about levodopa toxicity and can dopamine agonists delay motor complications? Again, levodopa toxicity is an old term. It is really, I think, definitively been shown that levodopa is not toxic. That's why I said that, and I tried to be clear. Levodopa does not cause progression of Parkinson's. It is not toxic. Can dopamine agonists delay motor complications? The answer is sort of. It is true that if you're taking a dopamine agonist, you're not going to be getting dyskinesias. But there are those other side effects like the impulse control disorders that in many patients can be much more problematic than the motor complications of levodopa. So it's not as simple as how can we delay motor complications with kind of a blind eye to everything else. It's what are the risks of doing that? So for the majority of people, the risk is they're getting undertreated for way too long. Question was how does alpha-synuclein pass the blood-brain barrier? It's a small protein that does that. Are there questions in the other chat? Is that what you're saying, Giselle?
Yes.
Hold on, let me stop share so I can see it. Okay, let's see. Any detriment to putting on medication as long as possible if exercise is working well? No, that's what I was saying earlier. If somebody's doing really well with exercise and they don't need medication, there's no detriment to putting it off. Again, the concept is there's no detriment to putting it off. There's no detriment to starting it when it's necessary. The problem comes when people develop what's called Levodopa Phobia, which is where they're so terrified of the side effects of levodopa that they put it off for too long. People are asking about COVID vaccine. We are not going to be a COVID vaccine distribution site. So please ask your primary care doctors as to whether they will be administration sites. Questions about driving after being diagnosed. So good question. You know, that is a very complex question. Short answer is that there's 3 aspects to Parkinson's that can contribute to problems driving. One is delayed reaction time. The other is abnormalities with visual spatial, like depth perception, for example. And the third are cognitive changes. And the bottom line is that it's not so much that people don't remember how to drive, it's just that these subconscious factors can contribute to less quick, less smooth, less appropriately safe driving. And so most people who've been recently diagnosed and are otherwise doing well can continue driving, but it really depends on where somebody's at with their disease. And if in the state of California, we as providers are required to report anybody who's an unsafe driver, but people can have Parkinson's and still be a safe driver. So the diagnosis itself isn't a mandatory report. Somebody asked a very astute question about, does Azilek slow progression of Parkinson's? So I sort of intentionally didn't put that in my talk because it's a little bit controversial. It's not FDA approved to slow progression, meaning it's not proven to the extent where, you know, everybody with PD has to be put on it because it's like the FDA is allowing it to be labeled as such. I think if you talk to 5 different movement disorders neurologists, you'll get 4 different answers about whether Azilek slows progression of Parkinson's or not. I personally, looking at the accumulation of data, do believe that it very likely does prevent progression. But again, I recognize that it's controversial and not everybody, you know, believes that. So I apologize for a wishy-washy answer. Question was, can I stop taking L-Dopa and take Rytary? Again, that's really a more specific question. But the concept is that if somebody's doing well on levodopa, there's no need to necessarily make changes. It's just that if somebody is, you know, having off time, they may need to make these changes. And then the question is, does COVID-19 exacerbate Parkinson's? Short answer would be probably, but temporarily, I would imagine. I think that was it, and I think it's 1:03. So I think I will end there.
Dr. P, can I just comment one thing about the driving though? Just a quick comment on that. While physicians or providers are required to report if your driving has become unsafe for you, sometimes we do recommend though that you do a self-reporting to the DMV. You can do it online. It may be a good thing, especially if you're really early stage. They may or may not call you to do like a test drive, which can be a good thing because I think legally, if you have reported it and something does happen, you get into an accident, whether or not it was caused by you. It is good that you have reported it to the DMV. Like I said, they may or may not call you in for drive test. So that was just what I was gonna say about it. So we are over time now. Um, anything else? Thank you very much for coming on today. We had a really good discussion. Thank you so much, Dr. Petrosian. There's a lot of information um, that you got today. Hopefully that is something that's helpful for you. We will be back next month, the first Monday of the month, which actually happens to be February 1st, I believe. Um, we will also have a recording of this session up in our website sometime probably before the end of the week, next week, the latest, most likely. We are going to be back next month, and next month, we are going to be talking about lifestyle with in relation to Parkinson's disease. So see you all next month, and take care. Stay safe, everyone. Have a great afternoon and the rest of the week.